Okay, I think we are live. So, very good evening to everyone who's joining in, and I hope all of you are doing good. Just waiting for a few more students to join, and we can start with the session. We will keep it very brief. It's a INICET Rank Decider series. In this session, it is meant for the INICET students, but even if you're targeting NEET PG exam or some other exam, obviously the topics will be the same, and you will be definitely benefiting from it. So I will be showing the question. Many of you have taken the test already. Some of you will be seeing the recorded version of this session. So let us start with the session first of all. And I will stick to what you barely need for that particular topic. Now, when it comes to INICET, if you look at the past papers, you will find a pattern. Every INICET, there is at least 2 to 3 questions, minimum 2 to 3 questions from neonatology. One jaundice question is there, one resuscitation is there, 1 or 2 questions from respiratory distress are there. So that comprises about 3 questions. You get 1 question occasionally from milestone. The milestone is plus minus in INICET. It may come, it does come, but it may or may not come this time. Then you get 1 question on either nutritional index or severe acute malnutrition. Then diabetic pregnancies and their related problems are a common area. Then IMNCA guidelines of pneumonia, diarrhea, and finally vasculitis and vaccination. These are the areas from where almost 40-50% of questions are asked. uh, we have already done MCQs related to the systemic pediatrics in the other YouTube sessions, so I will try to stick to the neonatology part, and I will be tackling the difficult questions today. So if whatever your level of preparation, please add these points to your notes, all the additional things that you find, and I hope you all benefit from it. So let us start with the session. I will be starting with question number one. A 39-week male is delivered apneic with poor tone. So there is apnea and there is poor tone. Heart rate is 90 per minute. Pre-ductal saturation was 62% at 1 minute despite warming and positioning. PPV was indicated. Why? Because apnea is there. Whenever there is apnea or heart rate less than 100, you have to start positive pressure ventilation, that is bag and mask ventilation. So this is a question asking about neonatal resuscitation. What oxygen concentration should be started for positive pressure ventilation? So different values of oxygen are given. So this is your neonatal resuscitation guideline. You can see the question on the left side, and this is the resuscitation guidelines on the right side. As I said, whenever a newborn is born, as soon as birth happens, you ask 3 questions to yourself. You assess the child. You can see in the photograph, term gestation, breathing, crying, good muscle tone. If any of them answer is no, you move further. Here the child is having poor tone. So we performed initial steps and then we assess the child again. Apnea, gasping, or heart rate below 100, you have to start positive pressure ventilation. So there is apnea present in this child. So you have to start positive pressure ventilation. What oxygen concentration will you use? Now, it is a very, very important point that whenever you have to start resuscitation initially, how do you start PPV? You start with bag and mask ventilation. No additional oxygen should be given if it is a term baby. I repeat, no oxygen is needed. Only room air, bag and mask ventilation is indicated. Why? Look at this point. It's very, very important. If you forget everything else in this question, the only thing you need to remember is if the baby is born less than 35 weeks, you start positive pressure ventilation with 21% oxygen. That is on room air. Room air has 21% oxygen. If it is baby born less than 35 weeks, you add minimal oxygen, 21 to 30%, because oxygen is also a drug. But 100% oxygen is needed where? Whenever you have to intubate and start chest compressions in the child. Here you are starting and it is a 39-week male child. So what you will be doing? Starting on 21% oxygen. So Ronak, Nehal, both of you have got it right. The answer is B. For those people who might be looking at the question and thinking such an easy question, remember you are sitting in INICET, negative marking 1 by 3 is there. Things appear easy when you are sitting in a relaxed way and solving or listening to the YouTube session. When you actually sit in the exam, it becomes tough. It is very easy to say to Jasprit Bumrah, why are you not bowling a Yorker? Even if you are a bowler, you would realize when you play how difficult it is. So that is why I'm saying questions look easy. If you are well prepared, questions look tough. But when you are on the other side, when you are actually sitting in the exam. It's an important point, important area you have to add to your notes. And please revise neonatal resuscitation. It's a rank decided topic if it gets asked in the exam. Let us move to question number 2. A 6-year-old child with severe acute malnutrition is started on nutritional rehabilitation. On the fifth day, the child develops sudden altered sensorium, and laboratory tests show no major electrolyte imbalance, and fundoscopy is normal. Which of the following best explains this phenomenon? Now, this is a child with severe acute malnutrition, and the child is undergoing rehabilitation. You know that whenever a SAM child is admitted in a hospital, two types of SAM is there, 𝗗cie𝘄𝗧𝗂𝘃 and Marasmus. Whenever a child is admitted, the total duration of hospital stay is 6 weeks. First week is the stabilization phase. Remaining 5 days are the rehabilitation phase. And whenever you rehabilitate, many children can develop phenomena. We call them as rehabilitation related phenomena. There are 4 important phenomena, and this question is asking you to make the diagnosis and tell the reason for it. Before we come back to this question, I would advise have a look at the nutritional rehabilitation phenomena. Answer is correct, Nehal, but I hope you have the reason to mention it. So, nutritional rehabilitation phenomena are of 4 types. You have the Kahn syndrome. Kahn syndrome is encephalitis-like illness. So these patients in early rehabilitation, sometimes when you give excess protein, they will develop altered sensorium. Altered sensorium will occur in early rehabilitation, so brain irritation features will occur, but it is self-limited. If you just slightly reduce the proteins and try to reintroduce them more gradually, the patient will improve. Second is refeeding syndrome. Refeeding syndrome is generally seen in marasmic children. Yes, good, Nehal. Marasmic children. When marasmic children who have adapted, they are given high calories. There is high release of insulin. Insulin causes dyselectrolytemia. The phosphate moves inside, potassium moves inside, magnesium moves inside the cell. This causes arrhythmia, CCF, and seizures, and that is called as refeeding syndrome. Remember that hypophosphatemia is the hallmark of refeeding syndrome. Third syndrome is nutritional recovery syndrome, also called as Gomez syndrome. Again, the cause for this is excess proteins in rehabilitation phase. Ascites, hepatosplenomegaly, gynecomastia, and eosinophilia can occur. And fourth is pseudotumor cerebri. These patients will have raised ICP, and so papilledema, headache, and vomiting can occur in these patients. Important thing to note, only refeeding syndrome occurs because of excess proteins. Excess calories. All the other things like nutritional recovery, pseudotumor cerebri, and Kahn syndrome, they all occur due to high proteins. So increased protein is implicated directly or indirectly in the other forms. Now go back to the question and try to make the answer. We go back to the question. This is the question. Now, question is saying there is sudden altered sensorium. No other major electrolyte imbalance is seen, which means it rules out your refeeding syndrome. Fundus is normal. It rules out your uh, raised ICP, so no pseudotumor cerebri, and no other problem is mentioned. No hepatosplenomegaly, no ascites, no gynecomastia, nothing. So you have ruled out nutritional recovery syndrome also. So what is the diagnosis in such a child? Tomorrow you may get a similar question. They simply ask you diagnosis. Diagnosis is Kahn syndrome. And in Kahn syndrome, what is the mechanism? A raised increase in dietary protein during rehabilitation. The rapid increase in dietary protein during rehabilitation is the answer. Nihal is asking me a question. Is there any effect on calcium during refeeding syndrome? No, Nihal. Secondary calcium abnormalities may occur, but because hypophosphatemia is happening and not hyperphosphatemia, so calcium levels generally do not get affected. Insulin is the reason for, see, total body potassium and phosphate remains normal, but insulin release in refeeding syndrome causes an inward movement of the electrolytes, causing all the problems, right? So there is no effect on calcium in those patients. Let's move further. So answer to this question is A. Question number 3. A term newborn delivered with good respiratory effort and loud cry. Heart rate is 140 per minute. They are different values are given. What is the most likely Apgar score at 1 minute? Now, my suggestion to you, it's apart from whatever we are discussing. Whenever you get an MCQ in the exam and the length of the MCQ is more than 3 lines. Always read the first few words and then read the last line so that you have an idea what are we talking about. Otherwise, you waste time reading it two, three, four, 5 times. So if it is more than three sentences, look at the first point and look at the last line. So it is a term newborn who has been delivered, and they're asking Apgar score. So basically, all the features are related to Apgar score. When it comes to your mind, then you can calculate it accordingly. So what is Apgar score? It is a score which is calculated at the time of childbirth in all babies. Normal babies we calculate at 1 and 5 minutes, and in resuscitation requiring babies we do it every 5 minutes. We do it at 1, 5, 10, 15, and sometimes 20 minutes is also indicated. So how do you calculate Apgar score? These are the four components, and on the left side you can see the question. So five components: appearance, pulse, grimace, activity, respiratory effort, and three types of score: 0, 1, 2. This is something we have discussed in theory, so I will not go into detail. Let us calculate the Apgar score. In exam, you will not have the table given. So heart rate is 140 per minute, so you give a score of 2. Infant shows active movement with flexion of all limbs, score of 2. Normal reaction to irritability. What is irritability? Grimace is called as reflex irritability. Remember, grimace is also called as reflex irritability. Sometimes the word grimace is not used. So what is reflex irritability? How do you check? You take a feeding tube, irritate the nostril of the child. No response, score of 0. You do like this, child does like that, grimacing, score of 1. You do like this, child sneezes, coughs, score of 2. Here, there is normal reaction to irritability, so you will give a score of 2. The baby remains, and the baby remains centrally cyanosed. Centrally cyanosed means the child is 0. And look at the upper one. Good respiratory effort and loud cry. So this is also 2. So except for cyanosis part, everything else is normal. Can it happen in a child? Yes, it can happen transiently in children. So total score in the child is 8. And C is your correct answer. So answer to this question is C, that is 8. Moving further, so Apgar score, you need to remember all the key features. You can be asked questions based upon this. Question number 4. A term neonate develops visible jaundice on day 3 of life. Total serum bilirubin rises at a rate of 0.15 milligram per deciliter per hour. And examination shows no staining of palms and soles. The infant is feeding well. No hepatosplenomegaly, neurological examination normal. Which finding would strongly suggest that this jaundice is pathological rather than physiological? So basically, they are asking you to distinguish. They are saying that this is not physiological, despite it looking to be benign. So what is the feature which is suggesting that it is pathological? This is what the examiner is trying to say. The bilirubin is rising slowly. There is no staining of palms and soles, no hepatosplenomegaly, no feeding well. So what is it? A, B, C, and D. What is the answer you would like to give? So Anuj and Nehal have answered correctly. Option number D is your correct answer. But how would you know that conjugated bilirubin comprising 30% of total serum bilirubin? This is conjugated bilirubinemia. Conjugated bilirubinemia in a newborn is always pathological. And so the answer to this question is D. Anuj, your answer is correct, but your reasoning is not correct. Kernicterus and basal ganglia involvement, option number D has got nothing to do with it. You have answered D, but your reasoning is not correct. This is conjugated bilirubinemia, which will not cause kernicterus, but still, any conjugated bilirubinemia is pathological. To understand that, let us do a brief discussion. Whenever a newborn comes to you, there are two types of neonatal jaundice. We have physiological jaundice and we have pathological jaundice. Now, what is physiological jaundice? It generally on appears on second or third day of life, so day 2 or day 3 of life, reaches a peak by day 5 or day 7, and then improves without therapy. It improves without therapy. It improves without therapy. Okay. Physiological jaundice, it is mild, it is unconjugated, and there is no CNS damage. There is no CNS damage. That is physiological jaundice. What about pathological jaundice? Pathological jaundice is any jaundice which appears on day one. Day one jaundice is always pathological. Or any jaundice with rate of rise of bilirubin equal to or more than 0.2 milligram per deciliter per hour. Or if a jaundice is having yellow staining of palms and soles, you will call it as pathological. Or any jaundice with encephalopathy, that will be pathological. Or any prolongation of jaundice beyond 2 to 3 weeks, that will be pathological. Lastly, any conjugated bilirubinemia in a newborn. If it is physiological, it has to be unconjugated. So conjugated bilirubinemia in a neonate is always pathological. And what is the definition of conjugated bilirubin? Equal to or more than 20% of bilirubin should be conjugated. People tend to think that conjugated bilirubinemia means conjugated fraction is more. That is not the criteria. The criteria says if suppose your total bilirubin is 10 and 20% of it, that is 2 milligram out of it, is conjugated, you will call it as conjugated bilirubinemia. So any one of these features, if it is fulfilled, you will call it as pathological jaundice. Now go back to the question and see whether it is physiological or pathological. Rate of rise is 0.15 milligram per deciliter. No hepatosplenomegaly. Neurological examination normal. Look at the options. Appearance of jaundice on day 2 of life is pathological? No. Conjugated hyperbilirubinemia without CNS signs? No. Peak bilirubin at day 5? No. These are all physiological. Conjugated bilirubin comprising 30% will suggest that this is pathological jaundice rather than physiological jaundice. INICET examiners ask simple things in complicated way. You need to listen to this discussion again with a cool mind if you are still finding it difficult to wrap your head around it. The answer to this question is D, conjugated bilirubin comprising 30% of total serum bilirubin. It's a tough topic, but please go through and add these points to your notes. So D is your answer. Question number 5. Now finally we come to treatment of neonatal jaundice, because treatment again, you will get questions in the exam. It's a tough one, this one. A 36-hour term neonate born to a healthy mother is noted to be visibly ectric. Total serum bilirubin is measured at 11 milligram per deciliter. The baby is otherwise feeding well and has no hepatosplenomegaly or encephalopathy. According to practical neonatal jaundice management guidelines, what is the most appropriate next step? So, see, there is no indication for doing exchange transfusion, and stopping breastfeed will never be the answer. So answer has to be among A and B, because exchange transfusion is done when phototherapy fails, if there is any severe incompatibility reaction, or when the patient has encephalopathy. Here, there is no encephalopathy, right? So A and B, which one to choose? The answer can be reached by two ways. First is the right-sided table. This right-sided table is the one that we discuss in the classes also. The guidelines say that whether you start phototherapy, whether you give exchange transfusion, or whether you don't treat the patient, that depends upon the total serum bilirubin value. At 24 hours, the minimum TSP bilirubin to start phototherapy according to IMS protocol is equal to or more than 10 milligram per deciliter. For 48 hours of life, it is equal to more than 13. For 72 hours, it is equal to more than 15. And for 96 hours and beyond, it is equal to more than 18 milligram per deciliter. Minimum TSB to start phototherapy, to do DVET, you can add 1 value to it, equal to more than 4. You can add 4 to it. So 10 plus 4, 14. Here the cutoff becomes 17. Here the cutoff becomes 19. And here the cutoff becomes 22. But the problem with this question is that there is no 24 or 36 hours value given. And that is why, Dr. Nehal, that is not true. That is not true. 24 to 48 hour more than 15 is not the cutoff. That is not the cutoff that we use. Now, we cannot depend upon this table. We have to come to this chart. This chart is called as American Academy of Pediatric Normograms. And what does this chart say? it says that categorize the child. What is this child? Have a look. This is a 36-hour term neonate. Term means it 37 to 42 week. So if it is 38 weeks onwards and well child, you will be using this wala cutoff. This one cutoff, the upper one cutoff you will be using. Okay, there are three cutoffs you can see. This one, and this one. So upper value you have to use as cutoff. Now mark 24 hours, 48 hours. This is 36 hours. 36 hours, what is the value given in the question? 11 milligram per deciliter. So mark it 11. Where is it coming? This is 11 milligram per deciliter. Has it crossed the threshold for treatment? The answer is no. Only if it goes above the topmost line, you will start phototherapy. In other words, in this question, you have to do observation alone. 11 milligram per deciliter, 36 hours of life. Private practice, people do treat. Corporate hospital, they do treat. But it is not an indication to treat according to guideline, according to MCQ, or in your clinical practice. Now you will say, sir, if table is not given, this chart is not given, how do you decide? This table can be useful. In general, you can add for middle values. Apart from this, you can remember for any midline value like 36 hours, the cutoff becomes equal to or more than 12 milligram per deciliter. And for something between 40 to 72, that is 60 hours, if the question asks, the value will be equal to or more than 14 milligram per deciliter. So these are the two values you need to add, and that is what we practically do. The answer to this question is observation alone. It's a very, very tough question. Ideally, we should not have got this question and we should not be discussing. However, we are discussing it because there is a thing known as expectation bias. I was reading, and it is a scientific thing. What is expectation bias? Expectation bias, I'll give you an example. It was a social experiment done. Everyone knows Henry Cavill, and Henry Cavill played the role of Superman. Just before his movie was going to be released, and he's a popular actor. One part of his movie had already come, Man of Steel. He's a popular actor. What he did was wearing a Superman T-shirt and no glasses, no makeup, nothing. He went into a market. He walked through the entire market for full half an hour. Not a single person came up to him. And there was a person who came up to him and he asked him for some random thing that may I know that pathway for that. He could not be recognized. Then the same Henry Cavill, next day there was a premiere of the movie. He went there. He was virtually mobbed at the place. And there he was not wearing the Superman t-shirt. What is the difference? The difference is expectation bias. When you expect certain thing to happen, your mind starts focusing on the thing accordingly, and your mind processes the information differently. When you're not expecting something, even if something comes in front of you, it will not register. It will not register to you. This question, if you have solved before, you know that this way also questions can be asked. If they give this kind of a chart, how am I going to mark in the chart and reach the correct answer? And suppose this same question gets asked, these are the additional values I have to add. Now your mind will process because it has seen. Now it will be processing the information differently. And that is the whole point of solving Q banks or solving PYQs and solving all types of questions. Every single thing you should practice PYQ, you should practice how it is likely to be asked as one-liner, how it is likely to be asked as case scenario. And that is where the rule of these videos, this INICET RDX session comes in. At INICET RDX session, at DocTutorials, we are creating a mix of questions for you. Topic selected according to the exam, but level of difficulty varying. There will be easy questions, there will be tough questions. The whole purpose is something will be asked from this. I don't know. I'm not an astrologer. I'm my videos are on DocTutorial, not on AstroTalk Talk app. But the whole point is, if you have solved this question and listen to this discussion and you just listen to it again, this type of question will not scare you in the exam. So what are the two things you will add? First, you will think that you will understand that how to mark if a normogram is given to you, number one, which you might or not have done. And second thing, to this table, you can add these values. And this will be a very safe table for you in the competitive exam. I hope it helps. Let's go further. Easy things will also come. Yes, Nehal, there was a mistake in the app. There was a mistake in the app. That is why I spent so much of time explaining it. Question number 5, answer is A. Question number 6. Now, question number 6 is an easy one. A term neonate born at 39 weeks is noted to have poor feeding and mild bradycardia on the second day of life. The nurse reports that the baby's trunk feels warm on palpation, but the extremities are cold and slightly bluish. Thermometer readings are unavailable. Which of the following best explains this clinical state? Now, if a child is feeling cold to touch and he's having poor feeding, etc., see, then you would suspect hypothermia. Ideally, you should check the temperature by thermometer and see what is the cutoff. So what is the cutoff for hypothermia? What is the definition of hypothermia? The definition is auxiliary body temperature. Auxiliary body temperature in a newborn less than 36.5 degrees Celsius. That is the definition of neonatal hypothermia. Neonatal hypothermia. Neonatal hypothermia is of 3 types. You have cold stress, you have moderate hypothermia, and you have severe hypothermia. Cold stress was previously called as mild hypothermia. Cold stress is 35 to 35.9 degrees Celsius body temperature. Moderate is 32 to 35 to 32 to sorry 35. Really sorry. Cold stress is 36 to 36.4 degrees Celsius. 32 to 35.9 is your moderate, and severe is below 32 degrees Celsius. Right? Now, this is applicable only when you have a thermometer given to you. Suppose thermometer is not given to you, how you are going to make it out? Simple. If you feel that the child's limbs are cold, also feel the central body. If hands are cold and central body is warm, that is cold stress. If peripheries are cold and central body is cold, the child has either moderate or severe hypothermia. You cannot call it as cold stress. Now look at this question. The extremities are cold and slightly bluish, which can happen due to environmental, stasis of blood. But central body, the baby's trunk feels warm on palpation. And so this is fitting into a clinical diagnosis of cold stress. So remember the simple rule. You do not have a thermometer. First of all, wash your hands, no sepsis, with and then warm your hands also, right? Not touch the child with a cold hand. Using the dorsum of your hand, first touch the feet, then touch the central body. Feet are warm, central body warm, no hypothermia. Feet are cold, central body is warm, cold stress. Feet are cold, central body is cold, hypothermia, either moderate or severe. To distinguish between moderate and severe, you cannot use the dorsum of the hand. So answer to this question is B, that is cold stress. Moving further. Question number 7. A neonate is found to have a minor external anomaly as shown. On further evaluation, which cardiac finding will be associated with this condition? Can you see in this child, there is hair present on the pinna. This is called as hairy pinna. And hairy pinna is very characteristically associated with which abnormality? Infant of diabetic mother. So whenever you find hairy pinna, it should raise the suspicion that the baby's mother was uncontrolled diabetic. Now, infant of diabetic mother is the diagnosis. Which cardiac condition is most common? The most common congenital heart disease in infant of diabetic mother is VSD. And what is the finding of VSD? Harsh pansystolic murmur at the left lower sternal border. Look at the other option. Option number A indicates ASD, wide fixed bleeding of second heart sound. Option number C indicates PDA, and harsh ejection systolic murmur with single second heart sound. It can happen in certain patients. If it is a cyanotic disease, it can occur in TOF, can occur in other conditions also. But answer to question number 7 is B, because pansystolic murmur is the hallmark of ventricular septal defect. So you first make the diagnosis, then you know the underlying cardiac condition, and then you come to the auscultatory finding. Question number 8. It's an easy one. One-liner masquerading as a proper clinical question. So a 6-year-old child with nephrotic syndrome has been given daily prednisolone at a dose of 2 mg per kg. but the child continues to be having proteinuria after several weeks. At what point you will say steroid-resistant nephrotic syndrome? Old guidelines, old books, they talk about 4 weeks or 8 weeks. Persistence of proteinuria after 6 weeks of daily steroid is the definition of steroid-resistant nephrotic syndrome. Remember, steroid resistance is defined if there is no response to steroid given daily for 6 weeks. 6 weeks of daily steroid is called as SRNS, sub one-liner. Let's do a quick review. Treatment of childhood nephrotic syndrome. Lots of questions are asked. They have been asked in previous year questions also. If they ask you what is the drug of choice in first episode of childhood nephrotic syndrome, the answer will be oral prednisolone. Oral prednisolone. Oral prednisolone. If they ask you what is the drug of choice in any relapse, the answer will be same, oral prednisolone. The answer will be same, oral prednisolone. Third, if they ask you, what is the therapy treatment in frequently relapsing nephrotic syndrome or steroid dependent nephrotic syndrome, you will have to use steroid sparing agents. You will give steroid, induce remission, but you will have to shift to steroid sparing agents. Which steroid sparing agent should be used? There is no clear answer. First agent to be started is levamisole. It's cheap, works in 50% patients, and it is less toxic. Second, you give a trial of mycophenolate mofetil. MMF is the short form. You must have read in pharmacology also and in medicine also, mycophenolate mofetil. And third is cyclophosphamide. Cyclophosphamide is not the initial preferred agent in such patient because it is a very toxic agent. In pharmacology, medicine, you read about its side effects, hemorrhagic cystitis, alopecia, gonadal toxicity. But cyclophosphamide is the most efficacious drug. If they ask you which is the most efficacious drug in the treatment of childhood nephrotic syndrome, which is steroid dependent, the answer is cyclophosphamide. Remember, cyclophosphamide, levamisole, MMF, do not play a role in resistant conditions. So what is treatment in steroid resistant nephrotic syndrome? Writing in bracket, no 6 weeks or longer, no response to steroid. You will use calcineurin inhibitors. Calcineurin inhibitors. You can use either tacrolimus, which is more efficacious, or you can go for cyclosporin. Either of the two can be used. If both are mentioned, the better answer will be tacrolimus. And lastly, is there any monoclonal antibody which works in severe refractory childhood nephrotic syndrome? Yes, there is a monoclonal antibody known as rituximab. It is anti-CD20 monoclonal antibody. So this particular series is very important. It is updated. And if you have read something else, forget it. If you have not read anything else, this is the one to remember. And please remember it. You never know. Sometimes easy one-liner question or case scenario followed by one line of this, that can be life-saving, that can be rank-saving for you in the INICET exam. Right? Good. Many of you are interacting and answering it also nicely. Good. Yes, Matthew is correct. Next thing. Question number 9. A 13-year-old boy presents with a history of fever 1 week ago, followed by migratory joint pain and swelling. On examination, he has a pan-systolic murmur, but echocardiography shows no residual structural abnormalities and symptoms have resolved. What is the most appropriate next step? Migratory joint pain, swelling, pan-systolic murmur, we are dealing with acute rheumatic fever. Now, acute rheumatic fever, you need to start on prophylaxis. What shall be the drug of choice? Benzathine, penicillin G. But what shall be the duration of prophylaxis? For that, we need to remember this table, this particular table. This is the question above, the same question I just showed you in smaller font. Now, if rheumatic fever is without carditis, the duration of antibiotic prophylaxis will be 5 years or till 21 years of age, whichever is longer. If there is carditis but without residual heart disease, no valvular disease, 10 years or till 21 years of age, whichever is longer. And if there is persistent residual heart disease, permanent damage to heart valve has happened, Then you have to give for 10 years or till 40 years of age, whichever is longer, sometimes lifelong prophylaxis. Now see, this child, he has a pan-systolic murmur at the apex, so carditis did happen. VSD was there. But echocardiography shows no residual structural abnormality. Symptoms have resolved. So he is coming in which category? He is coming in this category. And so for how much time you will give? Antibiotic prophylaxis for 10 years or till 21 years of age, whichever is longer. The answer to this question is B. Moving over, next question. Question number 10. 2-day-old term neonate presents with lethargy, poor feeding, temperature instability, total leukocyte count below 5,000, ANC below 1,800, CRP is elevated, blood culture report awaited. What is the next step in management? So what is the diagnosis we are looking at? Neonatal sepsis. Would you wait for culture report or give only supportive care? No. You will start empirical antibiotic. And what is the empirical antibiotic? We don't jump to vancomycin. We start with ampicillin and gentamicin. You don't throw a nuclear bomb when knives can work. So people will fight with fist. You don't throw a nuclear bomb. So start empirical antibiotics with ampicillin and gentamicin. What are the learning points in this? You should know. So this is the question. On the right side, I'm writing the learning point. If any newborn is presenting with lethargy, poor feeding, temperature instability means hypothermia. Rarely there can be fever, but generally it is hypothermia, plus minus other features like respiratory distress, which will be seen in pneumonia, or seizures, which will be seen in meningitis. You should suspect sepsis. You will suspect sepsis, neonatal sepsis. What is the investigation you will do? Do sepsis screen. Do sepsis screen. What are the 5 things we look for in sepsis screen? You check for leukopenia. Is there leukopenia? Yes, there is leukopenia. You check for neutropenia. Is there neutropenia? Yes, there is neutropenia. That is WBC count less than 5,000 and neutrophil count less than 1,800. These are the respective definitions. 1,800. Then you look for increased ESR. You look for increased CRP. And you look for increased immature neutrophils. We call it as band cell proportion. If any 2 are positive out of this, you start antibiotic. In this paper, you have all these positive. And so you will start antibiotics. Ampicillin, gentamicin will be started. But there is no role of oral antibiotics in such patients. So A is your correct answer. Matthew George is asking, in rheumatic fever prophylaxis question, we should follow ICMR guidelines, right? Matthew George, we follow IAP guidelines, which are the same as American Heart Association guidelines, which are the same as Nelson 22nd edition, which is the same as OPGAI 10th edition. So there is no difference in the guidelines. And this table, there are many versions of the table which are circulating. This table is the one that you are supposed to remember. If you open OPGAI, you will find this table, the new edition, not the older one. You open Nelson, you will find this table. If you open IAP, you open this table. And in all the medical colleges in the country, all the pediatric cardiology units, they follow this table. So this is the table that will be in the answer key if you are preparing for INICET or NEET PG exam. Next thing, question number 11. Match the following characteristic findings with the respective syndrome. It's an easy one. Even if you have a few atypical things, you can still reach the correct answer. So look at what is easy. Now, Alpine species, wherever you find this word with supravalvular aortic stenosis, hypersocial behavior means cocktail personality, loss of inhibition. We know that this is a patient with Williams syndrome. So 2 will come with A. Inappropriate laughter, seizures, ataxia, laughing episode. Patient dies of laughing, but low IQ. This is a patient with Angelman syndrome. We call them as happy puppets. So 3 will come with B. 3 will come with B. Then hyperphagia, obesity, small hands and feet. Prader-Willi, eats a lot, obesity, low IQ, and hypotonia. So 4 has come with D. So what is left? A1 will come with C. What is 1 with C? Lissencephaly. Lissencephaly is loss of sulci and gyri. I will write Lissencephaly means loss of sulci and gyri. Excessively smooth cerebral cortex, obviously they will have intellectual disability, and it is associated with a syndrome known as Miller-Dicker syndrome. Miller-Dicker syndrome. Some of these patients can have additional problems like absent corpus callosum also. So what is the correct answer? 1C, 2A, 3B, 4D. A is your correct answer. Yes, Kirti has answered it correctly. Question number 12. Tougher the question appears to be, easier is actually the answer. Question number 12. In the treatment of diabetic ketoacidosis, IV fluid should be started before insulin. First of all, you have to see, is the assertion correct? DK patient comes to you. Should you first start with IV fluids? Yes. Whether it is a child or adult, doses can vary, but first you will start with IV fluid because they are always having cellular dehydration. Second, early insulin therapy without prior fluid resuscitation increases the risk of circulatory collapse and cerebral edema. This is also a true statement. And that is why first IV fluids need to be started. So A and R are true, and R is the correct explanation of A. A is your correct answer. What are the things about diabetic ketoacidosis that you should know? Whenever a DK patient comes to you, in the first hour of management, you will always start with IV fluids. Which one do you use? In case of adults, you can use either normal saline or ringer lactate. Whereas in case of child with diabetic ketoacidosis, only normal saline is used. Ringer lactate has been shown to have a uh, poorer outcome. So only normal saline is to be used. IV fluid should be given for 1 hour. If it is shock, obviously different doses will be given. If it is a no shock, still cellular dehydration is there. First hydrate the child. Then you will start with, in the second hour, you will introduce, you will shift the patient to maintenance fluids, like you will reduce the amount of fluid which is being given, plus you will start with IV insulin. Many adult patients, you try to give one bolus of insulin, but preferred insulin therapy is always 0.05 to zero point 0.1 unit per kg per hour. So insulin infusion is always preferred over bolus. Can you give a bolus in adults? Some people try to give a bolus. It can be given. It is plus minus. But child, you will never give bolus. Always start with IV infusion, and then you will go for the subsequent management. So subsequent management depends. The same examiner will not ask you. What is the most common cause of death in diabetic ketoacidosis? It is cerebral edema. And cerebral edema is seen if insulin is given before IV fluids. If insulin is given before IV fluids. So answer to this question is A. Moving to question number 13. A 7-year-old child presents with high-grade fever, productive cough, rapid breathing, and chest retraction. The child has tachypnea, hypoxemia, bilateral crepitation. Obviously, the diagnosis is pneumonia. Child started on IV antibiotic. Day 6 of illness, he still has distress. And look at this photograph. Now chest X-ray is showing this. Can you see in this photograph? I'm making the boundary. I'm making the outline. Can you see this? Can you see this? And a small hair also. What else? My eyes, because I see X-rays, so I see differently than you. This one we cannot say, it can be stomach bubble also. So the lower one. So there are air-filled cystic cavities. This is a patient with pneumatocele. Pneumatoceles are air-filled cystic cavities forming in the lung parenchyma. It is a common complication of pneumonia, especially caused by staph aureus. Let me give you a better bird's eye view. This is the better bird's eye view. Can you see this? This particular thing? This is what it. So what do you do in pneumatocele? Nothing. Give IV ampicillin, whatever ampicillin, gentamicin you're giving, ceftriaxone you're giving. You add staph cover to that. Cloxacillin or vancomycin you will add. And expectant management, watchful observation will be done. They tend to improve with supportive therapy alone. You do not drain them, you do not intervene in them. Any damage to them, any intervention in them can paradoxically worsen the patient by pneumothorax. So always, give supportive care with antibiotics because it is pneumatocele. So this is a patient with pneumatocele. So Dr. Kirti is absolutely right. The answer is C, rightly mentioned by Kirti. Let's move further. Question number 14. What is the appropriate time for taking a blood sample to diagnose neonatal hypothyroidism? You never do thyroid screen in the first 48 hours. Why? Why? Bechara bacha has come with so much of, effort, passing through narrow birth canal, getting stuck, so many problems. And he comes into a noisy delivery room, which is his first, view of this world. He's having so much of stress. All this stress causes physiological surge in TSH level, and so the accurate measurement cannot be made. So what do? Let the child settle down. And once the child is settled down for 72 hours, then you will be doing. So the best sample time for neonatal hypothyroidism, it is never taken from umbilical cord blood 72 hours after delivery. And what do we do? How do we do it? We take heel pad prick, because umbilical cord is already gone by this time. So heel pad prick. And what do we check on it? Serum TSH alone. Serum TSH alone is done for screening purpose. Complete TFT is done. Complete TFT is done in case you want to make the diagnosis. And after this, you will also get ultrasound thyroid done, and you will get radio iodine 123 radionuclide scan. Radionuclide scan. Why? Because if these will be done if patient is found to be hypothyroid. If the patient is normal, no need to do it, right? And heel pad prick, it is a type of, we don't call it as dried blood spot. The reason being, we are not drying the blood. Dried blood method is same. You prick and you take, but here you do not take on a blotting paper. Here you take in a tube, so you don't let it dry, right? So, but the answer to this question is C. And also remember, the most common cause of congenital hypothyroidism is thyroid dysgenesis. It is thyroid dysgenesis. It is not agenesis. It is thyroid dysgenesis. Opig 10th edition, Nelson 22nd edition, Cloherty 10th edition, Ames protocol. Okay. Why am I saying? Because certain other textbooks like pathology textbook and medicine textbooks do talk about agenesis and dysgenesis, interchangeably. They're not the same. Okay. Question number 15. 15-day-old afebrile infant presents with a history of conjunctivitis, which has progressed to respiratory distress and pneumonia. Conjunctivitis in a newborn is superficial infection. Pneumonia is a systemic infection, sepsis. Chest X-ray revealed bilateral lung infiltrate. Peripheral smear shows leukocytosis. So it is not a typical sepsis, it is a atypical sepsis. Which is the atypical sepsis? First of all, it is sepsis, right? Any neonatal pneumonia is called a sepsis. But it cannot be streptococcus, it cannot be Neisseria, because they are the typical bacteria. They will cause leukopenia. Here it is leukocytosis. So it has either A or D. Now, out of A and D, which is the one which will cause both conjunctivitis and pneumonia? Mycoplasma will not be the answer. Chlamydia trachomatis is the correct answer. And so in these patients, you will consider starting IV azithromycin. Do you need to put something in the eye? If you're giving IV azithromycin, not needed. Some people prefer putting erythromycin ointment also in the eye. Personally, I'm not a fan of it. IV azithromycin is good enough, but guidelines are vague on that. So they will not ask you details. They will simply ask you diagnosis batao, drug of choice batao, right? These are the only things. Question number 16. We're on to the last 5 questions. As promised, we are well on track. We'll not stretch it beyond 1 hour, 10 minutes or so. Question number 16. 24-year-old man presents with bruising, petechiae, and occasional minor epistaxis. Symptoms do not interfere with daily activity, and platelet count is 45,000 per microliter. Whether it is a 24-year-old man, whether it is a 4-year-old man, whether it is a 64-year-old man, the diagnosis is same. Bone marrow examination reveals normal megakaryocyte. It is mild ITP. In mild ITP, nothing is needed. If it is asymptomatic, platelet count less than 10,000, then you consider therapy. Life-threatening bleed, you consider therapy. But here, nothing is there. Platelet count above 10,000, no serious life-threatening symptom. Education, counseling, and watchful expectancy will be needed. Remember, treatment of ITP, treatment of acute ITP is given if platelet count is less than 10,000 per millimeter cube, or there is a serious life-threatening bleed. And what do you give in these patients? You give IVIG followed by oral prednisolone. Favored one is IVIG, otherwise you can give prednisone. And there is no role. And if the platelet count is above this, only observation is needed, which is D as the correct answer. Question number 17. A 4-year-old boy is brought with poor weight gain. His mid-upper arm circumference is 11 centimeter. Is it less than 11.5? Yes. So he's having SAM. He's having SAM. On examination, he appears stunted with loss of muscle mass and subcutaneous tissue, including wasting of the buccal pad of fat. Which type of SAM? Marasmus. So what is the grade of marasmus in this child? Now, grading of Kwashiorkor is done based upon edema site, but grading of marasmus is done based upon what is the site of fat loss. Have a look at this table. 4 grades are there and corresponding site of fat loss. So grade 1, if fat loss occurs only from axilla and groin, we call it as grade 1 marasmus. It's a mild marasmus. Grade 2, if the fat loss occurs from thighs and buttocks, do you remember thighs and buttocks loss leads to loose skin fold? We call it as baggy pants appearance. So if baggy pants appearance have appeared and nothing else, you will call it as grade 2 marasmus. Grade 3, loss of fat will occur from chest wall, from abdominal wall, and from the back. That is grade 3. And what is grade 4? Loss of buccal pad of fat. Loss of buccal pad of fat. So what is the grade of marasmus in this child? D is your answer. D is your answer. It's an easy one. So remember, grade 1 is the milder form, grade 4 is the severe form. As you move from grade 1 to grade 4, severity increases. In Kwashiorkor, there is also a similar grade, but we depend upon edemas. Where is the edema present? In Kwashiorkor, pedal edema is grade 1, face in getting involved is grade 2, chest wall and back edema is grade 3, and ascites developing is grade 4. All these 2 grades are important, and I have discussed them in my detailed classes, and you can find them. In case you have any difficulty, you can always reach out to me. At the end of the session, I will tell you how to reach out to me. But if you are already a DocTutorials subscriber, you have already reached out to me, right? Then question number 18. 6-year-old boy presents with painful bilateral swelling near the jaw and cheek for 3 days. His mother reports exposure to a mumps outbreak at school 2 weeks ago. Dr. Kirti, visceral fat loss, Kwashiorkor, we do not decide based upon visceral fat loss. Kwashiorkor grading is based upon edema. Fat loss is a feature only for marasmus, not for Kwashiorkor. So mother reports exposure to mumps outbreak at school 2 weeks ago, which is the most common complication in this child. So remember, if you talk about complication of mumps in a child, most common complication is CNS complication. CNS complications can be either aseptic meningitis or they can be meningoencephalitis. Meningoencephalitis. Whereas in case of adults, the most common complication is orchitis, also called as epididymo-orchitis. These are the common complication of mumps. So look at this. It is C, meningoencephalitis, which is your answer. 6-year-old boy, adults and adolescents. Suran, be careful. Child, it is CNS complication. This is why this question has been put. I was waiting, and many questions, as I've been told, you have marked it wrong. If it was a 26-year-old boy, the answer would be orchitis. But if it is a 6-year-old boy, child, below adolescent age group, the CNS complications will be more common. Question number 19. Now, people may ask why. There is no proven reason for this, but there is a theory that in a younger child, the blood-brain barrier penetration is relatively easy. And mumps virus has a tendency to complicate and infect testis tissue only after it has matured. In other words, once puberty has started, the receptors for entry or internalization of mumps virus appear in the testicular tissue. You understand? So, before in the childhood, the receptors are not there, testis is small, so it doesn't cause inflammation. Exceptions can always be there, but it doesn't. So where does it go? It goes into the brain by crossing the blood-brain barrier. This is the theory I'm saying, that it is not proven yet. Question number 19. Unvaccinated child with fever, classic measles rash, bite or spot. What is the appropriate management? Okay, what is the appropriate management? Only vitamin A supplement, nothing, no action needed for the rash. Again, this will be tricky. Okay, great, Suran, great. Yeah, you will get a good exposure to these kind of questions. Look at this question. Fever is there, classic measles rash is there, bite or spot is there. Bite or spot indicates this is a patient with measles with vitamin A deficiency. If a child is having measles with vitamin A deficiency or any patient having measles with complication, you will admit the child. And what you will do for measles, supportive therapy, but you will have to give vitamin A supplements. What is the treatment of vitamin A deficiency? 0, 1, 14 days. Depending upon the age, you will decide the dose. So isolate in this situation along with the vitamin A treatment. Right? If it was only a bite or spot, you would have given vitamin A and sent the child home. If it was only measles, you would have, given conservative therapy and sent the child home. Here, both are present. Measles increases the risk of vitamin A deficiency, and vitamin A deficient child gets higher complication in measles, and that is why you need to admit these children. So answer is isolate in the institution along with vitamin A treatment. Yes, Rona, correct. Correctly answered by you. Good. Finally, dear friends, finally, we are on to question number 20. A 7-month-old child with acute diarrhea is being treated with oral rehydration solution. Great, somebody is giving ORS. Along with this, you need to give zinc. What will be the dose and duration of the zinc? For when zinc is the only micronutrient whose supplementation is mandatory in all childhood diarrheas, whether it is viral or bacterial. Dose duration remains the same, 2 weeks, 14 days. Dose depends upon the age. Age less than 6 months. The dose will be 10 milligram per day. And if the age is equal to or more than 6 months, the dose will be 20 milligrams per day. And the duration for that will be 14 days. 14 days. That is the answer. Kirti is asking a very good question. Why not MR vaccine, sir? Kirti, the whole purpose of MR vaccine is to prevent measles from happening. Already measles has happened. It is something like giving grand test on the evening of giving INICET exam. You gave INICET in the morning and then you came back home and started giving grand test. What is the point? If you have to give a grand test, you give it before INICET. You don't give it after the exam is done. Afterwards, so whatever has to happen has happened, right? So giving MR vaccine in a child who has already measles, it will serve no purpose, right? And even if you have to, revaccinate so that future it doesn't happen, then also you have to keep a gap of about 4 to 8 weeks. You will not give at the time when the appropriate management you have to do in the sick child. Okay, so answer to this question, 20 milligram, because it's a 7-month-old child, so 20 milligram per day for 14 days. D is your correct answer. I hope you all have understood. You all have, what are the points before I go further? What are the areas, those who are targeting INICET? Neonatology, particularly resuscitation, neonatal jaundice, respiratory disorders like RDS, TTN, please go through them. Very high yielding. Second, vaccines, please go through them. Third, Henoch-Schönlein-Purpura, Kawasaki disease, celiac disease, cystic fibrosis, CHPS. Go through them. 5 common congenital heart diseases. One of them can be asked. Go through severe acute malnutrition as well as nutritional indices. Also go through mucopolysaccharidosis and lysosomal storage disorders. Finally, lysosomal storage diseases. finally, please go through IMNCI classification of pneumonia and diarrhea. There is a very strong possibility something out of which will definitely be asked. Uh, would these only decide your rank and decide whether you go to INICET or not? No. To reach INICET, to crack INICET, you need to have a balanced preparation. But obviously, these topics and the revision will help. PYQ repetition and previous year topic repetition is more in INICET compared to NEET PG. So last 5-year papers of INICET, please focus on that. Any topic more than 2 times, read from the notes. You will thank me later. I think we are done. Kirti, should we watch Preterm baby package name since the last video uploaded was 4 years ago? Yes, Kirti, you can. If you have time, you can go through the preterm birth package. You can. Only if the time permits. If you're neglecting your own notes and looking at that, then it makes no sense. Thank you so much. Stay in touch. If in case you have any doubts, first one is my Instagram ID. You can scan and join me there. Any messages you've sent to me, I will try my best. And there is a WhatsApp channel. Late tonight, I will be putting some more MCQs, original MCQs related to pediatrics. Some of these might be useful to you, which will be followed by audio explanation coming 12 hours later. So you can always stick to it. DocTutorials students already know they are all members of FAIR. And you can also see how others are answering by looking at the percentages. Telegram link I'm not sharing here because close to the exam, I think it's better that you focus on. You don't get into too much of social media. So Instagram also only for messaging and only for doubts. Right. Thank you so much. Take care. I hope all of you do well. And please let me know if you need any of my assistance. Not just me, entire DocTutorials team is there to help you out if you need. Thank you so much. Bye-bye.
Recording stopped.